now. Um, Also, for future courses, conferences, or cases that you might want to look back on to think about in the future. And for me, this was written first, and then I went into OneNote. But whatever your system is, just making sure you're organized to be able to draw back on, especially with the important articles or readings. The second is developing protocols. And Eric, I don't know if you shared them, the stuff I sent, but I sent over sort of all of my protocols that I sent my MAs, my X-ray techs, what I have for my injections and follow-ups and whatnot. Um, and this has been really instrumental. I work at a number of different locations with a number of different staff, and this has really been helpful to let others help me. And so what this really happens is, I don't know if any of you are familiar with this infomercial here, but wrong coast, set it and forget it. So I'm able to show up to work. I'm able to, say I want a CMC arthritis X-ray series, and the X-ray tech can go get that. I see I want a CMC injection. They know exactly what I want. I don't need to tell them I need a 3cc syringe with a 27 gauge needle and the mixture of whatever I want to inject. It's all kind of done and set up. And certainly with follow-ups, when do I want to see my CMCs back? When should they see therapy? All of that stuff, it really allows for a more streamlined process. The other thing with this is, unfortunately, in today's world, we're seeing a ton of staff turnover. And so, a lot of this really helps the next person who's going to come along pick up where the other one left off, or otherwise you would have to retrain them. So spending time to get organized, developing these protocols the way you would want to do it, and updating them when you do update them is very important in this process. Maybe a little shameless plug here, but one thing that's been very helpful for me is having, therapy protocols as well. And so if you can't steal those from your mentors, finding a good resource that you want to use, and this is developed by our own therapists, but they kind of developed and wrote these protocols for all hand upper extremity pathology. And so we send these with our patients because they come from all over the state and even remote areas where there's no CHTs. And so having these protocols to send with them is very, very helpful. And so that can really help you get organized up front to have these, but also to ensure your success later. Probably one of the most important things to do now into the end of fellowship and even early before you start practice is to make your case cards. And so probably the most important exercise to think about the next couple months is how am I going to do this when I start practice? And part of that is developing your own case cards. So these are likely already formed. And so if you think of yourself as, Nina or Eric or Nicole's prodigy, and you're going to do things the way they want to do them, get their case cards, and hopefully they've been developed, but get their case cards, and then you can kind of update them and tweak them. And so you have a good starting point. And I'm 99% sure I provided mine. Obviously, we've not worked together, but at least it might provide a frame of reference to build off of. But these are kind of all the things that you might consider putting on one. And maybe the first thing that I would say is you start to think about how are you going to do this in practice, and maybe in developing these case cards is try to minimize variability. Like you yourself are not going to be reliable necessarily when you start. And so you want everything else to be reliable. You want to keep things simple. You want to focus on one system and master it. You don't want to try out a different, plating system every different, case, because then you're never going to get good at any one of them. And then, once you've mastered one technique, then expand your arsenal and attempt something new. The second thing is to get set up. Part of this is filling any gaps that you might have had, any deficiencies in training. And so, like Eric, I didn't quite do a extra time internationally, but I did go to an AOS course because I wanted to get a little bit more, hands-on formal training for shoulder. Before I started, I also did the orthopedic educators course because I wanted to go into training. And also did a coding course because that's very pertinent for running a private practice. So all of these are things that were deficient potentially in my training that I wanted to round out. So thinking about what those are, utilizing the beginning of practice when you're not necessarily as busy to round out that education. It's really hard to take the time off later to go do these. The other thing is developing a system with good customer service. And getting set up requires this team of trusted people. And sometimes you may go somewhere where there is control, or sometimes where there's not control. But if you do, definitely be part of that hiring process for who you're going to work with so that you can ensure you have good front-facing staff. Many of patients' complaints are about scheduling, about billing, about messages being unanswered, wait times, friendliness. And if you can control all of these, you're going to really have a great patient customer experience. And that's very important as you're building your practice. The other thing is having great therapists because they could really make you look good. And a part of this team also involves not only referrals outside of your practice, but also partners and regional specialists. And so the referral network that you have that you will send your own patients to can be as important as the referral partners that you have that send patients to you. And if you can be kind of the go-to, like, I have arm pain and you find out that they have actually a neck problem, you have a great neck person you send them to. I mean, you are still that patient's kind of savior in their mind because you found the solution, the cause and the solution for their ailment. And so having good people to refer to, like neurologists, radiologists, for either second opinions and of eyes on an MRI or ultrasound evaluation of your flexor tendon repair if you think it might have ruptured. And these are all people you really want to get established with early to have that good network of people to help you care for your own patients. The others are the partners or regional specialists. And these are people you're either going to ask for help on cases. If you want to co-scrub a case, you're not comfortable with one, you want some help on either with advice on a case or to scrub with you, but also someone to send them to if they're beyond your scope of practice. And then finally, as you get started and getting set up, you want to have a marketing strategy. So whether or not you're at academic, private practice, hospital employed, I mean, you want to build your practice. And so having some way to meet and greet, to announce that you're there, some degree of marketing strategy is important. Kind of a next step in getting set up is developing your schedule. And so I provided kind of my schedule both here and in the attachments, but early on, you definitely want to maximize new slots. So new patient slots are the lifeblood of any practice. Unless you're getting a new patient coming to see you, you're not going to then convert that to a surgery or kind of active ongoing treatment. And so, one thing that's important as you get more follow-ups, meaning like you have post-op patients, you have patients that you injected for their trigger finger, you have ER follow-ups or call follow-ups from the ER that you may or may not have seen. You want to avoid having those take your new slots. And so trying to find a good system that you can kind of efficiently see those follow-ups. And some of that may be not having patients come back for the fourth or fifth time after their trigger injection just to make sure they're doing okay. But trying to figure out who to make come back, who to not come back, and then how often to see patients can be very helpful. Trying to find this balance between new patients before your schedule gets choked up. And then, the one other concept, so you can see that add-on slot. So that's a concept that we have in our own practice, just about being available in the local community. But having that independently or individually can be also helpful if you are trying to be the guy that has the availability and you're going over to, you're marketing yourself as a new guy. Hey, I'm free. Please send me your patients. I can get them in super quick. You always want to be able to kind of come through on that promise. And so having these slots where people can come in and last minute notice for kind of urgent concerns or problems can be very helpful. And thinking about reevaluating this workflow every couple of months. As I said, wait time is one of the more common complaints. So you want to think about this timing as you're going on. Obviously, you're going to be slow early. You want to think about limiting this, but as you get more comfortable, you figure out how your workflow is going to work, how you work through patients. Optimizing this and thinking about timing to make sure that patients aren't waiting is important. The other thing and the trick that I picked up from my residency was always apologizing for someone's wait. Even if they sat down 30 seconds ago, they still waited for 30 seconds. So apologizing and appreciating, acknowledging their time, it can be very helpful in this regard. And then always sitting down. They've done a number of studies on this, but sit down, that really helps the patient not necessarily feel as though they're being rushed. So kind of the next phase that you're going to go through as you're kind of getting into practice is getting busy. And for anyone that's in kind of my generation, I immediately think of Sean Paul when I hear these two words. But part of this in the first few months is just being available, as I said. And so all of us, I think, probably know the three A's of physician success. So availability, affability, and ability. Probably the most important is just being available. That's being, the path of least resistance, saying yes for partners with urgent cases, for anyone needing help, for ER needing assistance. And that, if you say yes, you kind of be that path of least resistance, then they're going to think of you and go to you when they have additional patients for you. The other is ER. So obviously call can be an easy way to fill your clinics with patients and also easy way to fill your OR schedules early on. So that's going to be very important early. And from an ER perspective, again, having direct connections to you. Someone has a fingertip injury, they want to know if they need to have some, it's an open P3 fracture. Do they need to treat that urgently or not? Can they wrap it up and send it to your clinic? Giving them your phone number so they can text you and figure out what to do with that patient and get them a home is all they want. And that direct pathway can be established pretty easily and without much sacrifice of giving your phone number and answering a couple texts. And that can really lead to a great referral source of patients. And again, you want to be kind of that easy flow for patients and that easy button for staff. As the first year goes on, you want to maximize your clinic time. And so part of this is, as I said, early on, it's going to be call, it's going to be trauma. That's not necessarily the best lifestyle. So trauma cases are unpredictable. They come with the added challenges, not only your own kind of shortcomings, but every trauma case is just a lot less predictable than a carpal tunnel or a Seamster arthroplasty. And so, you want to think about maximizing your clinic time to get more elective cases, maybe make your lifestyle a little bit better. The other, thought process here is that every non-op patient that you treat initially is going to potentially convert to an operative case later. And so you're really kind of setting yourself up for the future the more clinic you have early on. The other thing to do as you kind of get busy early on is develop a regional presence. So that's meeting people, getting to know people, and that could be involved in committees, either in your hospital network, your own practice, regional communities. But that can be very helpful for kind of meeting and greeting people. And then finally, if you have an interest in work comp, that is a business that is desirable from a private practice standpoint, not as desirable from either a hospital employed or necessarily academic standpoint. And so that is a potential market that you could tap into, and giving talks, meeting people, and even offering education, the CEUs or that education offering for work comp can be very helpful to kind of get your presence and reputation built. The picture at the bottom right is early on, if you're joining a practice, and especially if you have partners, you kind of want to think about making the pie bigger, not taking your own slice of the pie. And so, if you're starting another location, you want to say, I'm not going to fight for the patients that you have, partner A. I really want to come in and I want to, build our business and our practice in this environment or this type of surgery. And so that's one way to really make good with your partners and also try to grow your group's business. The other thing to really focus on early is your online presence. Early on, you have zero online presence, and so there will be negative reviews, especially as you work things out. Making sure you drown out those negative reviews with positive reviews is very important, so you don't just only have negative reviews online. And so we have an automated system that's Radar 8. Early on, I had a handout, which is in the top right, that I believe I also shared with you. And that's just really getting happy patients to try to go online to give positive feedback. Google is actually not there on my handout, but that ends up being the most probably important one. So trying to drive people to Google to give you reviews on Google is probably the most important. Kind of the two other avenues online, one is your online bio. So having nice detailed personal information, stuff about your background can really make you a little more personal and also attract patients to you. And I've had been surprised early on. I was kind of a nobody in my practice, and I had patients read my bio and chose me over my senior partners, which is just always very surprising. So that can really help drive business to you as well. And social media, both for younger and aging generations, is also an avenue to explore there when building your online presence. From a long-term growth standpoint, the happy patients are your best referral source. So that will grow organically, and that will grow over time. And unfortunately, that doesn't help you early when you're kind of chomping at the bit to get busy. But harnessing any happy patient for the reviews really helps build the online presence, build your reputation, and so trying to capture these when you do have happy patients can be very helpful. And then kind of finally, the old school way was going and meeting and greeting, primary care doctors, ER doctors, internal medicine, rheumatologists, and that can be very helpful not only to build your own personal network of people to send to, but also from a referral source if you do have the time or opportunity. And then lectures for those people can be helpful. That can generate, educational credits, which then can potentially help drive referral sources for a particular niche if you have an interest. And then, evaluating and making sure that those referrals are still sending patients to you, but also evaluating why that you might have lost that referral can be helpful as you're building long term. I'm going to transition a little bit to just talk about finding a niche or building a niche, and just talk a little bit about my own personal experience with that recently. But this is another way of getting busy, maybe more mid to long term. But I'd say many hand surgeons kind of find themselves in a particular niche, whether it's scaphoid, shoulder, plexus, soft tissue coverage. I mean, the list goes on. And I think that's one, very neat thing about our field is that you can take it many, many different directions, or all the directions if you want to stay more general. But often people gravitate towards a little, portion of our field with what they really enjoy doing. And first thing with, choosing a niche or developing it is to be interested. And obviously, if their interest isn't there, then it's really hard to continue on. This is similar to your decision to go into hand surgery. But once you have that internal desire, you need to really be dedicated for both the patients and professions to stay that expert in that particular field. You also want to think about kind of the worst patients and complications, and is this something you're okay with seeing? Are the interesting cases, do they outweigh the negatives of some of these kind of disasters that you may or may not inherit from being that subspecialized surgeon? And do you enjoy reading on this? Most of hand surgery is an evolving young field, and so a lot of this will change as years go on. And so does this interest you enough to continue that lifelong learning? One way to separate yourself as you're developing this niche, especially if you're young, is to be more knowledgeable about it. And so that's sort of how I ended up, I think, a little bit serendipitously more kind of, at least internally, known for nerve surgery. And that's really just by being excited about it, reading the literature on it, and kind of knowing more about it. So at journal clubs, I'd speak up, and at least internally, people would start to talk to me, ask me advice on cases and what I might do. And so that could be very helpful early on as you're trying to self yourself apart. The other thing that is critical is just being technically excellent. Obviously, if you want to be the best, the shoulder surgeon in your area, but you're really not good at it, you probably are going to fizzle out at some point just through negative outcomes. And so you want to, if you do have a particular niche, you obviously want to be technically good at that. And so, and this is a focus of mine still, as I continue to do more and more nerve surgery. One thing that I've done and just been very critical of is taking a ton of pictures of it. And so going back, looking back on them, thinking about it, and I look at pictures of cases I did a number of years ago, and I kind of snicker a little bit and saying I won't necessarily do that again the same way, or make that clinical judgment. But I think that's very important here because this is an evolving field, an evolving career. And then, if you do have good outcomes, others are impressed, and you can become the go-to within your either your own organization. So this is sort of my pathway, I guess, to kind of where I ended up. And I'm going to maybe get a little personal with this niche development, but in general, you can generalize this to whatever you really want to go into. But I started with simple pathology when I just started, carpal tunnels, cubital tunnels, digital nerve repairs, and then evolved more into revision surgery, atypical compressions. And part of this complex pathology is you can never necessarily say no to what someone wants to give you if you want to keep building this. So if someone had a complication, they cut a nerve, they've done 3 cubital tunnels and they're still not doing well, and they want to send the patient to you. If you want to be that person, you need to say yes to those cases as well. And that can lead to becoming the go-to for a particular subset, either in your practice or region. And that personally then kind of dovetailed into generating, at least internally, a nerve program. And so we launched this a couple years ago. It's not necessarily unique compared to what other centers do in the country. I think it's maybe a little bit more unique for a private practice that doesn't necessarily have everyone together or have the other resources that maybe more larger academic centers have. But we started this with a number of my partners. You probably recognize a good bit of them. But it's been a ton of fun. And one of our challenges that we faced was really building this niche, but within a private practice of well-known hand surgeons. And so it's kind of like Eric saying, "Hey, I want to be, the scaphoid guy," or vice versa. And so, thinking about, trying to do this, but do it in a maybe delicate way where others are also maybe experts in this field. And so for us, we had to get other approvals buy-in. And part of this is generating a win-win scenario. And so, this really does apply to really any negotiation. So we as a group wanted to start this, but we didn't want to, cut into our other partners. And so part of this is we kind of pitched it as, hey, we're going to grow the pie. We're not going to really talk about taking your cubital tunnels, taking your carpal tunnels, taking your nerve lacerations. We're going to talk about, the plexus, the nerve pain, the neuromas, the amputees, lower extremity, spinal cord injury, things that we didn't either necessarily see all of or that my partners didn't necessarily want to do. So growing the pie, but also providing an area to kind of send patients they may not necessarily want to see. And so really our partners have been the best referral source so far. If you do want to, get into this, for us at least, we started with, best practices of other groups that have already done this and kind of reviewed internally, workflow, fine tuning, kind of all the stuff I really just talked about developing our own practice. We repeated for the nerve program. And then marketing is a kind of a big component of this. And these are all the different things that we're currently doing. Obviously, I'm very involved with this and can talk probably ad nauseum about all these different little things that we're doing. But just to kind of show you everything that we have been doing from a marketing standpoint, probably the most successful ones have been highlighted here. And then, personally, I've been wanting to foray into lower extremity trauma, and this has been a little bit challenging just because as a Indiana Hand Center, we're not really known for lower extremity, so that's a little bit of a market shift. But also, I think there isn't necessarily a referral pathway that currently exists for these patients. And so I think we did a little bit of market research, but they're out there, don't really have a home. And so this is, something we're still doing. But that kind of was a long segue of kind of a little personal journey, but that was, processes of getting busy both early and maybe mid early career, and developing a niche if you wanted to get into one. Kind of one of the next things to do as you're getting into your career is to get through challenges. And bonus points to anyone who can name what this is from. It's one of our kind of our dirty pleasures right now, or guilty pleasures, I'm sorry. But one of the challenges you're going to face is how to operate alone. And so first things first is scheduling extra time. This probably has been repeated to you multiple times, but book your cases for maybe 1.5 times what you think you're going to do early on, because you're always going to hit unexpected challenges. Trauma cases are always unpredictable, as I said, and that's going to be a larger proportion of your cases early. And this helps you manage your reputation. And for some, especially in the OR, they'll start talking. The ORs are kind of like middle schools, and that they always talk. And so for some, a fast or on-time surgeon equals a good surgeon, not necessarily. What outcome you have or what the quality is of your repair. But if you're on time and fast, they think you're good. And so trying to manage that reputation and staying on time is important. Part of this is doing a mental and physical walkthrough. So most people don't know what they don't know as they're getting started. And so they don't know they need to, think about, the certain retractor or the setup because they're going to, hit this road bump down the road. And so trying to do that mental physical walkthrough, looking at the back table, seeing what they have, making sure that, they got the instruments that you need from central processing, or they didn't contaminate a set and they don't have what you need. But then also having plan B and C and trying to schedule and post for those, including all of those in your plan. Are very helpful, so that when you do run into problems, you have some anticipated outlets for correcting the ship. One other thing, and I'll maybe mention a couple examples about this, but perform one task at a time is very important. I think when you're operating alone without another skill set of hands, so if it's just you and a scrub tech, you need to think about your scrub tech doesn't necessarily know what they're doing, and you need to free them up to go actually hand you instruments and go open sets and whatnot. And so having a system and having a stepwise approach and knowing how to use your skilled hands for the most important things. And a part of that is kind of focusing on doing one thing at a time, not, if you have that proximal phalanx fracture, not holding a reduction, getting your starting point with the K-wire and then passing it all at the same time, really breaking that down to each step of the procedure so that you can free up your hands, just focus on put your K-wire in the right spot to start, then advance it to the fracture, then get your reduction, then push it across. And all of that really kind of breaks it down into one simple task rather than being this kind of complex thing where you don't have enough hands to accomplish. The same can go for distal radiuses. And so having different tips or tricks to kind of use the plate to help with the reduction, which is kind of what's depicted down in the bottom left, or things to help with your reduction, like finger traps or traction. Personally, I've looked at extending your incision distally and doing the extended FCR to really see over more ulnarly, get rid of, edematous tissues or patients that have a little bit more bigger body habitus. But these are all different tips that I've kind of picked out along the way, but that can really make your life easier and save yourself in these certain scenarios. the other one is obviously nerve, and having certain setups to allow for retraction or cutting jigs for nerve cutting, or even your repair technique can be very helpful to kind of think about how you're going to do this without having someone that can hold or touch a nerve. If you have your scrub tech pinch your nerve and hold it in place as you do your repair, they're going to crush it and you're going to have to cut that second nerve out. So just really thinking about how you're going to do things in a stepwise approach. And part of this is also not forgetting your lifelines. So the top right is our, co-fellow chat, and you guys, I've heard have a great fellowship class, and I'm sure we'll have this chat continue to go afterwards, not only with social, life events, but also with advice. This is one that we had early. What to do with these types of patients can be very helpful to ask your co-fellows. But also your mentors, partners, and even online outlets like our society has, both the email listserv, but also communities online. And for Nerve, there's Doc Matter. But this was me early on. I frequently went down to Dr. Greenberg and asked him what I should be doing. Kind of the next step with this is getting to routine. And so hopefully, at this point, you've gotten busy, you've kind of worked through challenges, you've set yourself up, you have your organization in place. And so now it's really about kind of fine tuning this machine. And part of this is setting your goals. And so, once you get busy, maybe you get partner, maybe that's your first goal. But including your partner, your family with this planning is very important, because that helps you kind of schedule things, helps you decide what you say yes or maybe defer. And for me, actually Paige Fox kind of talked about this in her resident fellows lecture she gave a couple of years ago, but putting things on a schedule. I live by my Google Calendar. If it doesn't end up on my Google Calendar, it doesn't happen. And also it's not prioritized. And so we sit down every week, we talk about the week, we talk about the month, we talk about kind of commitments that we both have, that we have for our own family, and make sure that everything is prioritized appropriately, and everyone has kind of the same expectations. And that's been successful for us in trying to define a routine, but also have this work-life balance that we all strive for. And the final thing is get help. And, this is something that definitely was on my radar early. Like, I knew I was going to kind of put my head down and grind early, but I knew I needed help to make this successful, because I knew I wanted to teach. I wanted to get involved with society. I wanted to, have a good work-life balance. And some of that does not generate RVUs or a profit. And so needing to have help to either be productive while I was here or even have help when I'm not here was very important. And so that could be an APP, which you can theoretically negotiate in. I know many of you have probably already signed your jobs, but certainly can be negotiated in upfront, or it could be goals moving forward. Kyle Everlin swears by a scribe. He talks about that being one of the most life-changing hires he had. But certainly trainees can not only bring fulfillment to your practice, but also extra hands in the OR, assistance, and as well. And so these are all different avenues to go down to get help. But I would certainly start thinking about that early. And if you haven't signed, certainly potentially negotiate into your contract, or potentially your contract renewal if you kill it in your first few years. But that's all I had today. Hopefully that combined with the handouts would be helpful as you're starting to kind of transition into your next phase of your career here. So with that,
That's awesome. Thank you so
take
much.
that any direction or answer any questions.
Yes, that's awesome. Why don't we open it up, and then I have some questions. So both of our fellows are on, Tom McQuillan and Joe Manero. I'll let y'all introduce yourselves and engage with Brandon.
Yeah, sure. I'm Tom McQuillan. Thanks so much for joining us, and a huge thank you for being generous with all of your documents and your protocols. It was a monstrous amount of information. I read through a bunch of it, but it's super appreciated, and it's definitely something I think Joe and I are both looking forward to assembling sort of these last few months of fellowship, sort of picking and choosing the things that we like from all of our own attendings. And now we have your preferences as well to choose from too. One thing, I guess to lead it off, that I've been thinking about is how you sort of plan for some of these decisions around extra help, allocating certain responsibilities to people with the pressure of boards collection. And I'm wondering, when some of these decisions sort of were then delegated to other people, particularly with, patient communication on the portal, how you're following up with people after surgery. Because I imagine as I'm continuing to learn too in my first couple of years of practice, I'll sort of want to be seeing some of these complications and successes firsthand. So wondering how you kind of negotiated that.
Yeah, I mean that's a great question and still I think a very difficult balance to hit. But the I think the issue is that there's no good answer to that. And so I basically didn't have help until after that. Partly that was financial, part of that was a personal decision to kind of avoid having that during boards. But I laid eyes on every incision. I made sure to take out all sutures. I went and met every single patient, including call patients at both of our level 1 trauma centers that we took call on. Didn't have the fellow take them back. These are all things that I did. I mean, realistically, the boards are looking for you to practice like you would normally practice. They don't necessarily want you to act any differently. And I think it's very reasonable to have APPs. I think most people do. Most people in training programs have trainees see patients. And so as long as you're acting, I guess, appropriately in the patient's best interests with the information you have, I think that's I'm not a boards examiner, but that's what I think that boards examiners would be looking for. And so, and for most clinicians, that involves some degree of APP level seeing patients. And so I think it is very reasonable to integrate an APP early. I think it's just, using the information in patients that have issues, making sure to be available, making sure to work them in, have them come see you, seeing them between patients in clinic, see them early, just doing the right thing for the patient if there is an issue.
Thank you.
Hey, I'm Joe. I'm the other fellow. First of all, great talk. Thank you so much for taking time out of your evening to give that. I know Tom and I have been talking a lot amongst ourselves about starting our practices, and it's exciting and nerve-wracking.
Yeah.
So I've got 2 questions for you. First, fairly straightforward. How long did it take into your practice until you really felt like you had got the swing of things and you were in your groove, and I guess until the imposter syndrome faded away? And then the second question is, how did you approach doing new cases that you had never done before? Either stuff that was newly described in the literature or just stuff you hadn't come across until that point?
So 2 great questions. So I finished my second year in practice, and I was talking to my senior partner, Bill Kleinman, and I was like, yeah, I'm feeling kind of good. And I'm starting to get feel like I'm just, on my feet a little bit more. And he said, wait till you're 5, then you'll feel good about it. I was like, oh, thanks. I really do think that's true. I think you're too kind of past boards, you're worried about less. But I still don't think you're fully in your groove. I think year 4 to 5 is when I really felt completely comfortable. And it was a little bit more fun, less nerve-wracking, less kind of go, and a little bit more just enjoyable. And then the second question was how to kind of adapt to something new. Actually, it's interesting. I gave a talk about this at the Academy meeting a year or 2 ago, but yeah, so that is a very kind of hard decision to make. And I think some of it, obviously, if there is a product or a development that is clearly better than something that came before it, one example potentially could be intramedullary narrowing of metacarpals. I think in my mind, those patients do better. So I think that's something that you might choose to do sooner. I think otherwise, unless it is clearly better, as I kind of said during this talk, I mean, I would focus on one or particular few cases and really master them. Because if you keep introducing new products, new techniques, new solutions, you're never going to get fully adept at one of them. And I mean, not to be a shameless plug, but I use a lot of Acumed for distal radius, and the first 3 or 4 years I developed more and more tricks about what I could do with the volar plate, about getting my reduction, getting different fragments, securing different fragments. And then I picked up TriMed and I started doing more with them, and, figuring out kind of how to use the plates in different ways and secure different fragments with different approaches. And so, I think getting comfortable, don't introduce new things when you're not a master of one of them yet. And I think that's probably the most basic answer to that question. But once you do feel very competent with something, then I think it's very reasonable to start introducing other things that don't clearly have a superiority.
That makes sense. Follow-up question for you. At what point in your career did you start feeling comfortable um, getting involved in the industry side, doing the talks, getting involved in design, things like that? And how did you broach that?
So at least in my experience, that was a little bit serendipitous. So Jeff Greenberg, and that happened through sort of my partners, but he knew of my interest in nerve, and he just basically told Oxygen that they should have me give lectures, and so I started doing that. And I think I don't know honestly, but I've been told, at least by them, that if you do well, then they start asking you to do more, and so that's kind of, if you do put some energy and interest into it, and you kind of succeed in I mean, that's true with society as well, but if you kind of are asked to do something, you do it well, then they usually come in back and ask you to do more. And so that kind of led to a couple different things, and then some of it's having ideas and or having conversations. And so if you do want to get into product development, there's kind of whole different concepts about IP. Obviously, you want to be careful with what you say and how you say it, but um starting to have conversations with the industry. And I mean, I partnered with, one of the other industry partners, and, combined to help develop a product. And so I think that was a little bit serendipitous, but that just came from having conversations at the meetings about that.
Awesome. Thank you.
Two of our other, or a couple other residents are on. One of them, Zaman Hussein, is actually applying for Scholl Noble Fellowship right now. And in the process, literally, I think has 2 or 3 more weeks left of your interviews. Is that right, Z?
That's right. Yeah, I had a question, Dr. Smetana. Thank you so much for your time and wonderful talk. I've been making so many notes on this. This is really great stuff. Even though it's a few years away from me, I'm sure it'll creep up on me. One thing I wanted to ask a little bit more about is your efficiency, workflow, and tips throughout the week, and more specifically, like when you plan cases, when you prepare for them, who you let know, who in your team do you let know about the plans? When do you sign your clinic notes? When do you call patients back? Those kinds of things. Any kind of tips along the way to make your workflow more efficient that you picked up?
Yeah, I think that's very person or clinic dependent. I think I could share what I do for efficiency, but I think that'd be very different with what you eventually do. But I think the bottom line is, and I've talked to a couple of people about this recently, but finding those little pockets of time and making use of them. So, I'm walking from the OR to the next OR. We run 2 rooms, but I'm going to go talk to a patient and block them, and then go talk to family. But I look at my phone, and it's not the best thing, but I answer emails during that time. Jim Chang talked about never putting something back down on his desk, and so I try to emulate that because I think that's very helpful. So something that comes in, if I see an email, I try to answer it and get it off, because otherwise you're in the OR and your emails just blow up. Same thing with a paper or journal review, whatever you're doing. If I try to not touch it multiple times, because then it's just creating inefficiencies. I have multiple hour-long commutes. I schedule phone calls during the commutes. So either call family, friends, consulting calls. Those are, I try to make best use of every minute of my time, so that when 5 o'clock rolls around, I can come home with my baby and be home with our family. And then scheduling things too. And so if I'm going to work out on a Wednesday and I have clinic, I'm just going to put it on the calendar. Everyone, that helps a little bit at home personally, because then everyone knows what I'm going to do and when I'm going to do it. But I think that also helps with motivation. It helps with kind of expectations. I got to get my clinic notes done, because I'm not going to have time to do them later. I personally try to find the most time during the day to capture work, because I want to try it when I get home to not do work.
That's great. Thank you so much.
That's awesome. And one of our other residents, actually next year, is going to be applying to hand, and you'll probably be seeing her that way. Julianne is on. She's a 3rd year right now, finishing a 3rd year, so I'll be applying to hand next year. Ben?
Hi, I appreciate your talk. Thank you so much. I think this is super important. I think there are a lot of questions that we had answered with just your general knowledge and experience of actually breaking out into the real world as real hand attending. So really appreciate that. Personally, I did want to ask, when you kind of are first starting your practice, I think there's so many different ways that you can get involved and continue your education and your involvement through all the different societies. But is there like a um, way that you established a group of physicians around you, or I guess kind of like we talked about, maybe previous co-fellows or co-residents that you draw upon or kind of bounce ideas off of or ask advice from, or if there's like a group in your area that you kind of get together with the hand people and um, can talk about cases or just find fellowship in that way.
Yeah, so from an advice standpoint, I think that came fairly organically through our fellowship. I mean, not to talk it up too much, but we have a couple hundred, fellow alumni. We're on a listserv with everyone. Our fellows email that listserv every day to kind of ask questions to everyone. I think that was maybe more pertinent for the senior generation. I think now every fellowship class, and some of that's going to just a fellowship, a little bit bigger group. I personally have 6 co-fellows, and so we text all the time. And then when I really don't know what to do, I just ask Eric or Nina or Nicole. I think, some of that just happens organically. And I think part of that is choosing your fellowship, thinking about those sorts of things. I think that was something that I really wanted as well. The other is, the more people you meet through society or through association or whatever organization, the more the bigger network you're going to have. And so I think personally for me, I'll text people and hopefully our hand club develops a little bit more into this, but thinking about that, using that network and those resources for those types of questions. I think a lot of hand surgeons at least use the society for that. So as I said, there's a listserv, and that there are communities that people ask a lot of questions to. And so if you're maybe somewhere where you don't have that community, I think the society can really be a good resource for that. There's also lists of journal clubs that happen regionally, that if you are kind of in your own private practice, you can go join those to help stay up to date, but also maybe formulate that network of other trusted people that you might ask questions to. I know there are a couple people kind of senior to me that have had regional hand surgeons come and double scrub certain cases with them. And so that's not unheard of. And if you are in a smaller community, those are resources available.
Really cool. Thank you.
It's awesome. Gotcha, Nina, Nikki, you guys have anything for Brandon?
No, all smart advice. As you get further in practice, things become, I wouldn't say less interesting, but sometimes doing the more challenging things and seeing the complications afterwards make you kind of change course or change direction a little bit. But yeah.
I am constantly humbled. I think you're totally right, Brandon. After 2 years, I thought, oh, I'm good. I got this. And there's always a surprise later. So there's always something like, oh, that's interesting. And I think I think one of the benefits is most definitely when you're in an academic center, for sure. Like, your trainees really do challenge you to stay on top of things. So trying to learn new ways of doing things, trying new techniques, it's constantly humbling. I think that's the one thing, which is why our fellows will definitely, including Joe, will go to an academic center.
My favorite, I don't know if I ever told anybody my favorite quote, which is actually from my brother, which I think I was like just out in practice. I was like, oh, I did this sweet case today, or I did this. He's like, yeah, nothing ruins a great case like follow-up.
Mm-hmm.
Yep.
For sure.
Isn't that true? No, that's fun. Yeah, Brandon. No, well, thank you, man. This was awesome. One question for you. If you were going to go back and do something different, so you obviously were extremely organized and extremely efficient in how you did everything, admittedly much more so than I was. What would you have changed? Like, now let's say you went back to your fellowship and now you're coming out. What's one specific thing that you'd be like, all right, I should have done this because this would have made my first 5 years like a lot better?
Maybe it's more what I shouldn't have done.
Yeah.
Um,
Okay.
but yeah, I think my personality is probably coming across, but I'm very like I'm type A plus. And so I think I went a little overboard with some of that. You know, as I said, I think, I met every patient, I saw every wound, I took every stitch out, I think that was a little ridiculous. I think it kind of killed work-life balance for the first couple of years. And I think I stressed a little bit too much over boards and, being perfect, I guess. And so, it is the practice of medicine. It is not perfect. And I don't think they necessarily expect that from you. And so, I don't know how many of all of you are super nervous about that, but I certainly was. Um, and I think maybe taking it down a notch would have been my advice to myself.
I don't know,
How
putting
did
a
you
general
evolve in that? Like, when did that come to realization? How did you eventually evolve? Like, how are you balancing that now?
Yeah, I think it is stressful. I think, I think about it as, certainly if I saw and did everything, I think that's certainly maybe the best thing for the patient, but you can't do that. And so I think you got to accept that. And making sure the patients are in good hands. I'm currently, I just hired a new APP, and so I'm training her, and just trying to make sure that the goals, the basics, um everything is set so that patients are being cared for appropriately. But yeah, it's hard. It's anxiety provoking. It's hard to kind of hand off something when it's kind of your name on it, and also you don't, it's not only your name from a medical legal perspective, but it's also what you want for your patients. You want the best. And so it is anxiety provoking for sure, but I think it's just the reality of patient care. I mean, I go to 4 different locations that are hours apart in the state, and there's no way that I could be everywhere all at the same time. So I think kind of just accepting that, uh maybe being a little bit more zen about things, and not worrying about the things that I can't control, and just making sure that when there is something I can control, taking care of it appropriately is really kind of how I maybe morphed into where I am today.
Very cool. And one last question for you, because both of our fellows this year are headed into sort of teaching positions. How did you balance the need to get up your own learning curve, or advance along your own learning curve, while at the same time effectively teaching and exposing the trainees with you? Like, how did you find that balance, and how have you sort of morphed that as you've gotten further along, become more and more of a master?
Yeah, so what I did at the beginning was what I thought was very helpful when I was a junior resident was talking through everything. So every step I did, at least in the OR, even if I was a little bit more hands-on early, I would talk through everything, thinking about the thought process, think about your reasons behind every step, every decision. And part of that was putting it on the trainee beforehand to talk through it as well. If they could describe exactly what they were going to do and how they're going to do it and why they're going to do it, then I was maybe a little more comfortable handing the knife or instrument over. And so, that was number one. So talking it through both pre-op, intra-op, and then post-op is one way I felt like I could educate while maybe being a little bit more in control of things early on and growing myself, but also not necessarily want to give the knife over when I didn't necessarily know how to fix it if they were to screw it up, or being judged during that board collection period. The the other thing is, what I do more now is I really focus a little bit on what I talked about or touched on, is how to operate alone. Because I think that was probably the hardest thing that I had to transition towards after training. Pretty much, at least for me, the entire stage of training, I always had either another resident, an attending, someone that at least, even if they were being a dumb assistant, knew how to hold a retractor or touch something. The hardest part was just being me and the scrub tech, because I couldn't take my scrub tech to, be hands-on with me at the case, because then there's no one on the back table. And so first off, anticipating maybe, and you can ask for second scrubs. So asking your hospital for second scrubs, if there's a case you need it for, like most shoulder cases, I just say I need a second scrub. The other thing is, and so what I really focus on now is really how to operate alone. And so again, the stepwise approaches I kind of addressed, and all the things I may have picked up along the way about how to free up your hands and really focus on doing one thing at a time to kind of move forward throughout the case.
That's awesome. That's awesome. Any other questions you'd ask?
No, this was super helpful because it's like, Brandon, even though technically I've been in practice for quite a while, like, because I was in Canada, and Canada has like this unlimited, like 2-year wait list as soon as you kind of start your practice. So like coming to the US, this was like a huge adjustment for sure, like building a practice. And to be honest, like I'm not very good at it. I'm not very facile. So I thought this was great. This was super useful for me as well.
Yeah, this was also really great for me. This was a great talk. I feel like, honestly, like kind of once you're not past some of this stuff, but it's like after you've experienced it, then it like really makes sense. I think listening to this talk as a resident, I wish I had it and been able to internalize it a little bit more, because this is such sage advice. So I hope our residents were taking notes or go back and watch it again or something like that. But this was awesome. Thanks for coming virtually.
Thanks for having me. This is an honor, and it was really fun meeting you all virtually. And Eric, hopefully I'll see you again sometime
Yeah,
soon.
thanks, Brandon. And as I mentioned, maybe sometime in the summer or the fall, I'd love to actually bring you out here in person just in the weekend.
Yeah, that'd be awesome.
We'll be in touch, but it would be fun. Fun to have you come out here and join us. So
that'd be great.
Well,
have a good night. Enjoy the last word if you ever make it.
Yeah, I love it. Can you send out the recipe again?
Yeah, absolutely.
All right, cool.
All right, good night, everyone.
Take care.